Hello everyone, my name is Sue McCutcheon and I am the Renewal Lead for the South West LHIN, and I'm looking forward to telling you a little bit more about creating subregion integration tables in the South West LHIN. The subregions for the South West LHIN have been officially approved, and this map that you see on the right hand side is the official subregions for the South West LHIN. You see Grey Bruce in the north, Huron-Perth in the centre, London, Middlesex, Elgin and Oxford in the south. Certainly subregions are a major part of how the vision of Patients First will be accomplished, seamless, consistent, high quality care. It is really the way that we think we'll be able to move work forward in a way that's consistent and unique to the population. And I would say the last thing is really about us working together differently in a subregion area. Many of us have a long history of working together in those subregions, and this gives us an opportunity to continue to improve that. When subregions were formed, there was lots of discussion about what they will and will not do. So subregions will not result in more bureaucracy. Subregions will utilize the existing LHIN staff in more effective ways so that no new organization is formed. Subregions will not impede the obligations to engage with provincial and regional partners and patients. These will obviously continue. And subregions will not infringe on traditions or established jurisdictions in the planning, delivery, or improvement of health services, in particular our Indigenous and Francophone populations. This slide is a picture of how the new committees or structures within the South West LHIN will interact together. So you see the subregion integration tables across the bottom of this slide. You see them depicted via map so that you can see Grey Bruce, Huron-Perth, London, Middlesex, Oxford and Elgin. Each will have their own subregion integration tables. Of those, there will be 3 patients and families that will be part of each of those subregions, and 2 of those people from each of the subregions will sit on the Family Advisory Committee, and you'll also have a patient and 2 individuals from each of those subregion integration tables make up the Health System Renewal Advisory Committee. All of these structures, all of these committees are meant to support the renewal work in the South West LHIN. All of these 3 structures or committees are coming from the same moral compass, and we've spent a lot of time over October, November, December into maybe early January really out talking to lots of stakeholders about what it is that should be our guiding principles for these particular committees. And so you see these listed here: person and caregiver centered, equitable, aligned to population need, integrated across sectors and systems, borderless access, trust and respect, transparency and sustainability. These 3 committees or structures all have the same overall aim, including the subregion integration tables, and that will be to improve the health, wellness, patient experience and outcomes, as well as value for money. We know that 10 to 15 members are great for decision making from a flexibility and nimbleness point of view, but that when it comes to work, there may be lots of other people that you may want to involve in work, and so time-limited work groups may also be formed to really move and support the work moving forward. Initially, we think the chair will be appointed by the LHIN from the membership, but the intent is that over time that will be elected by the members. And we just think because of the amount of work that's happening within these tables that they'll likely need to meet monthly. The subregion integration tables are made up of 10 to 15 individuals. This slide really describes how those people will do their work. They want to enable, enhance and champion collaboration between all of the patients and providers. They do want to establish the priorities for the subregion. They want to make sure that those priorities include consideration of the Francophone and Indigenous people in that subregion. They also want to ensure local alignment with the LHIN and the LHIN-wide programs. We do think that working together to reduce duplication and integration of services is where we'll see the greatest opportunities, and there's a shared responsibility to ensure that that happens. They will also leverage current communication and reporting structures in order to share information, and many of those structures are already in place in the subregions. What work will the subregion integration tables actually do? Well, first and foremost, they need to build trust among the providers in the community. In many of our subregions, this is already well on the way, but we want to make sure that all providers in the community are involved in that trusting relationship. Knowing the actual profile of health and wellness of the community will be important. Subregion improvement opportunities will come out of that profile and could be things like creating shared capacity, integrating programs and services, coordinated care, and certainly standardizing approaches to care. So we understand that building common goals and an improvement plan together will be really important to ensure coordinated care occurs. Local targets need to be set so that improvement plans can be achieved. The group may also provide recommendations to the Health System Renewal Advisory Committee or to the LHIN that really build on priorities that cross geographies, opportunities to leverage enablers such as e-health enablers, and certainly ways to achieve shared responsibility. They will be responsible for reporting on progress as to their meeting of targets in their improvement plan. They will establish an agreement that will demonstrate shared responsibility between all partners. How will the subregion integration table move to shared responsibility? We do understand that this is an evolving process. You start with building relationships, evolve to joint responsibility for integrating care. We may want to sign fairly early on a shared commitment statement to help us move along that trajectory, with eventually maturing to the point where we can actually sign an accountability agreement. The subregion integration table will actually have membership that will reflect the following perspectives. Addictions and mental health, this is a large and diverse sector, and it will be important that we have a representative to bring forward that perspective to the table. In London Middlesex, it is important that we have a French language service representative, and so we'll be seeking a member particularly for that subregion. Hospitals will have a member at each of the subregion tables. From a home and community care perspective, there will be two members that we will be seeking. One who is responsible or has connections to direct service functions of the CCAC. The second will be around community support services, and we will be starting with the lead agency that's currently been identified in each subregion, and hope that over the long term that will move to a nomination process. In the subregions of Grey Bruce, London, Middlesex and Elgin, we very specifically will be seeking out an Indigenous representative. It's not to preclude that the Indigenous representatives could also move forward to the Huron, Perth and Oxford subregions, but for sure those three where we have First Nation communities will be important for us to have an Indigenous representative. Long-term care, we have many long-term care homes across this LHIN, and so we do want to make sure that each subregion has a long-term care representative. I talked a little earlier about patients, families and caregivers, and that there would be 3 per subregion. And just to note that we will be going through a public process, an expression of interest process, in order to ensure that we have patients and families and caregivers in each of our subregions. The next 2 bullets are around primary care. Certainly there'll be a representative from primary care administration, and so that would be from a nurse practitioner-led clinic, a family health team, or a community health center. Those people from administration in those organizations, we would have 1 representative from them. The other primary care representative will be a clinical representative. And in the beginning, we do believe that will be the subregion clinical lead. In the long term, the co-chair of the subregion primary care network can become, or we hope will become, the clinical primary care representative. Public health will have a representative. Other perspectives that each of the subregions may want to look at to ensure that they have a broad and diverse membership. So non-health representatives with a regional view and social determinants of health perspective. So that could be someone like the police or emergency medical services. It could also be physician specialists who bring a particular perspective on a particular need in each of the subregions. The criteria for anyone who's interested in becoming a member of the subregion integration table: strategic system thinker, broad knowledge of the system, strong leadership skills, the ability and status to influence system leaders, peers and partners within the subregion, the ability to represent the perspective of the sector, and I'll use mental health and addictions as an example. That's a very large and diverse sector, and it's important that whomever represents them has the ability to bring that full perspective. Recognized for leading and working collaborative with all members in the community, ability to work collaboratively with stakeholders, experience working on subregion initiatives, broad knowledge of the subregion in respect to healthcare, social services, political priorities and inequities in health. And I think this is really the richness of a subregion integration table, where we do bring local leaders who have that deep knowledge of how the subregion works to ensure that we make improvements moving forward. They also need to have experience in addressing the inequities in health that arise from the social determinants of health. And those again are very global in nature and yet have unique perspectives in each of our subregions. And we're also wanting to make sure that people are aware of or represent the diversity in the community, and in particular French language services, Indigenous, Mennonite, etc. So thank you very much for your interest in subregion integration table membership. Please, if you have any questions at all, don't hesitate to contact us.